Hello and welcome to Legal Thinking. I'm Liam Pape. Ahead of International Day of the Midwife, which is this Sunday, which is the 5th of May 2024, I'm handing you over to my colleague Hannah Blackwell, who is a Senior Associate in RWK Goodman's Birth Injury and Medical Negligence team. In this episode, she speaks about the challenges facing midwives and how those challenges have changed with two midwives. She speaks to Frances Fraser, who qualified in 2010. She currently works as a bank midwife, providing antenatal, intrapartum and postnatal care across all areas of the delivery suite and community. She also works as an expert witness. The conversation is also with Jenny Fraser, who qualified as a midwife in 1975 and practiced clinically until 2012. During her career, she worked as lead midwife for clinical governance in maternity, paediatrics, sexual health and gynecology. She led on risk management, clinical incident reporting and root cause analyses. She continues to work as an expert witness. So without any further ado, let me hand over to Hannah.
Hi Jenny and Frances, thank you for joining us on this podcast. So I wanted to start really by asking you a bit more about your experiences as a midwife. And I wondered firstly why you chose midwifery as your profession.
I wanted to do midwifery from a very young age. There was a midwife lived across the road from where I lived, and I was friends with her daughter, and I was absolutely taken by the pictures in her midwifery books. And I got a bit obsessed with it and decided at that very early age I wanted to be a midwife. So in those days, you did your nursing training first for 3 years.
Yeah.
And then it was seen as being quite prestigious to go and do your midder. So after I'd done my 3 years, I went into midwifery, which is what I'd always wanted to do, and then never did anything else. Frances?
Oh, I never knew that. That's such a nice story. Mine's a little less romantic, although I retrained in my 20s. I'd worked in childcare from leaving school and in nursery nurses and as a nanny in London. And I realised that I wanted to retrain, and I started just sort of looking into what my options were. And then when I discovered midwifery and started sort of looking into it, I had a sense that it was potentially what I was meant to be doing. So it was definitely a calling, as it were.
Oh, that's great. And then looking how things have changed over the time. Jenny, you qualified in 1975 and France, I think you qualified in 2010. How was it when you qualified in 1975, Jenny? What were the sort of challenges that you faced at that time?
I think one of the biggest challenges was that we didn't really have any idea about woman-centred care. And everything was done by rote and by the book. And the sisters ruled the roost and you did as you were told. So every single woman, you didn't treat them as an individual. They would come into hospital, they would put their gown on, and then even if they were really contracting in late stages of labour or whatever, they still had to have their pubic shave, an enema and a bath. And the enema was a big tube with about a pint of whatever it was. We used to say it was high, hot, and a hell of a lot. And the poor women, were trying to cope with contractions often, but this is what you had to do. And I found that really quite challenging, because there were times when I just wanted to look after the woman and not do things by rote. So that was, and the obstetricians also, there was a hierarchy, and they were the ones who dictated also what went on. So it was quite a regimented field to be working in at the time.
Did it take time for that to change in terms of that hierarchy?
Yes, it did. And it was the women themselves that started changing things, and groups like AIMS, the Association for Improvements in Maternity Services, which is still going, that became a spokesperson for women who were taking their complaints and things. Because as a hospital, we didn't get complaints. I can't remember any litigation. But they were going to these outside organisations and expressing, their concerns. And then there became a sort of movement to actually listen more to women and to make the care more individual for each woman.
I think we see that, playing out a little bit more, as the years have gone by. And I think, when I then qualified in 2010, there was definitely this focus of woman-centred care and, all these sort of, there was, at that time, there was, alluded to choice. That was a bit of a rhetoric, I guess, because I think, I don't know how true that choice was in 2010 to where we've come to now. But, I think what also potentially has changed from listening to what Jenny said is actually that autonomy for the midwife, it
developed, didn't it?
Yeah.
Because you didn't have that same autonomy in 1975. And the women didn't have a choice. The women that came into hospital, well, they could choose whether they had a home birth or be in a maternity-led unit or the hospital. But if they came into hospital, there were no choices. They had what I've just described when they entered, and they had to take their clothes off and put a hospital gown on. And they just had no choice in any of it. They had to stay in hospital for a minimum of 48 hours and not go home any earlier than that. So, I finished working in 2012, and of course I saw the change there to a more individualised approach to women. One size doesn't fit all, does it?
No. And actually that's really, I think, where we are now from 2012 is really choice is a massive part of, women's, birth experience and pregnancy. And I think we'll see that progressing even more, to be honest, with things like Montgomery and the, the implications that's having on clinicians.
Yeah. Consent was never an issue when I first qualified. You didn't ask for consent for anything.
Yeah.
You just did whatever without ever asking for consent. And of course that changed dramatically, particularly now, as Frances says, with Montgomery, consent is a huge issue.
Well, yeah, and I think we had a whole module on consent when I did my training. It's really a massive part of,
Yeah, that's interesting.
Yeah.
I didn't get that.
Yeah.
Has that changed then led to a change in terms of how women are giving birth when they have more choice?
Well, I think so, because the women when I was first qualified were on their backs in bed, and not allowed to get up. I use that word allowed, but that's just how it was, really. And then it did develop. Women did start moving around, didn't they? And then we got some bean bags and some birthing balls for people to have different positions, whereas that wasn't the case. They were flat on their backs in bed and didn't get off the bed.
Yeah. And you were saying that a lot of the drive for change has come from women themselves and sort of groups that have developed over the years. How has that impacted sort of on the role of the midwife today? Where there is much more focus now on consent and choice. I was just thinking in terms of now there's more of a focus on choice and consent. So in practice today, sort of how does that impact on the role? I'm envisaging that you're asking for consent in many situations, and there's a lot more discussing with a patient about what is important for them.
I think it does, it is impacting on clinicians, and I guess the comfort of clinicians, because, we have all this guidance and all these guidelines some of it's based on evidence, about how we keep women and babies safe.
Yeah.
And some of the choices that women might make might sort of be contrary to that information that we have as clinicians, and that, if you think our overarching motivation is this safety, and then you're presented with patients who don't want to accept that, those offerings, I suppose.
Yeah, that's a difficult situation, isn't it?
Then it becomes a difficult situation, and then we're saying, well, it's the woman's choice, but actually you're the clinician providing care. So, the sort of examples I'm thinking of are women who there's sort of a whole kind of this is something that's rising, I would say, is women wanting care outside of guidance is the term. And the RCM have written some guidance to support midwives in these circumstances. But actually, if we think about birth rights as well, women, essentially, it's their human right to make a choice about what happens to them and their baby, and the baby doesn't actually have rights until it's born. So, that's, I think that is a real challenge for clinicians, midwives and obstetricians alike.
Yeah, I can see that. I can see that really clearly, that has become much more of an issue, hasn't it, over the years that has developed.
How are you advised to manage that situation?
I don't know if there is advice really to manage that. It's something I think we're all learning as we're going, like a lot of what happens within care, and perhaps in 10 years we'll look back and we'll know more. I think it's very individualized, and it'll be lots of people will have had different experiences of it, because there'll be a group of midwives who fundamentally believe and are happy to support women's choice, and there'll definitely be another group who think that shouldn't be the case, I suppose. And I don't know if that will ever change, or
there's some natural, I suppose, not conflict there, but difficulty in the balance of knowledge and what's important to an individual, I suppose, isn't it? Sort of knowledge of medicine and what's important to an individual.
I think people also, we think we have all this information now as well, so I think that would probably be something that's changed over the years, is the readiness of information. And we have all this evidence, growing evidence base, but also, women are more empowered in that they can access lots of different information by the internet or through other groups. It's definitely there's been this growing movement of groups and bodies of activists who will be advocating for choice and against intervention. Because that's a big part of what might motivate women around choice, is women are used to the risk of having intervention in birth.
I'm just listening to you talk about your experiences, and particularly, Jenny, in terms of how it's changed since 1975, when you were talking about the earlier experience of women going into hospital. It just sounds quite traumatic. But see, we're now currently in Maternal Mental Health Awareness Week, and have you noticed with these changes a change in terms of our understanding of maternal mental health?
I can't ever recall mental health being discussed when I was first a midwife. It just wasn't an issue at all. I mean, that's something that has developed, people, you've got women who are, got post-traumatic stress disorder from their experiences of birth. And you get, people talking about their birth experiences to counsellors or to midwives, who do that sort of work. Whereas that just was never an issue.
No.
I think it's a huge part of the agenda for us now in this climate. Suicide is the leading direct cause of maternal deaths, in the up until 12 months postnatally, and that is such a shocking statistic that, like you say, I guess that's something that's I can't think how many years that's been the top cause, but it's been definitely the last 5 to 10.
Longer, I think. because I remember, because I left in 2012 and it was a leading cause then. So it's actually quite a long time.
Yeah, that's over 10 years ago, isn't it now? So
yeah.
What are your main concerns about the maternity services at the present time?
Well, Frances can answer that, but one of the things that changed during my time as a midwife, and I practiced from 1975 to 2012, was when I was first midwife, we didn't have staff shortages.
Yeah.
Midwifery was seen as being a sort of prestigious profession to go into, and it was very popular. And I cannot recall staff shortages, but of course, as time went on, I became very aware of it. And before I left, I was the midwifery risk manager, and I also worked clinically. And staff shortages were a daily occurrence, and that is really hard for the midwives, trying to juggle with competing demands and work when there's not enough midwives around.
Yeah.
The times working clinically when it was really, really busy, but if you had a full complement of midwives, it was fine.
Mm.
It did get very stressful if you think, right, there's more women coming in and where are the midwives to look after them? Yeah. So I don't know what Frances thinks on that.
Yeah, I think this sort of the rolling kind of impact, I think, of all the austerity sort of measures that have been impacted on maternity provision, which has led to staff shortages and the workload being quite complex. And so, the impact that has, I think, on morale and culture, it's like a vicious circle, I think. And I think that it really does come back to staff shortages a lot of the time. If you think people aren't getting their breaks because there aren't the midwives to cover them, they're working long shifts back to back, often full time, because of we haven't had a very good wage increase. So it's quite difficult times for people. And actually, they're working really long hours in a really stressful job with not enough staff, not getting proper breaks. And then, we have the junior staff or our students that are coming in who need support and guidance and, nurturing to do the role. But they're sort of, the people that are leading them are burnt out and in this, really sort of highly kind of, a compassion fatigued state, I would say. So that is definitely, it is a concern, I think. And I think it's impacted on culture in all of the maternity services across the UK, because that's what we're seeing in all of these reports. That culture comes up as an issue, and I would say that potentially is one of the main causes, probably.
Yeah. I went to some training recently, and Jill Walton, Chief Executive of the Royal College of Midwives, was talking about priorities for the maternity workforce. And she mentioned that 85% of midwives work beyond their hours to fill in the gaps. And while this goodwill props up the service, it eventually demoralises it. And is that something you've seen?
Yeah, definitely.
I can believe that.
Yeah, it's such a high percentage, isn't it?
It's a huge percentage. And I mean, when I work clinically, regularly would stay on, you'd be there extra hours. You just couldn't leave. And but that didn't happen when I was first qualified. Just because there were plenty of midwives around. And I just don't recall at all there being any staff shortages.
I think it's difficult it's almost difficult to talk about this stuff because it's been such a long, this isn't sort of new information. It's not, this isn't a new phenomenon. And, the trusts that I'm working at the moment actually aren't going to be able to employ the newly qualified midwives.
Really?
So we've got, student midwives in their third year who are about to qualify, and they at the moment haven't got a job in the trust that they've trained at because, but there's all this investment, there's all this proposed investment in maternity services. It's hard to get your head around, to be honest.
Because of funding.
I don't really know. And I think a lot of it is outside of a lot of our understanding, or, it doesn't, we talk, if you talk to people, the general public, everyone says, oh, but aren't we crying out for midwives? Everyone knows that, that statistic kind of thing.
Yeah.
But it's not matching up with what's happening in the provision.
No. And because this isn't like a new information, we've known about it for some time. Is it something that's been happening since you qualified, Frances? Presumably this is something you've always known as a midwife, I'd imagine.
Yeah, it is actually, yeah.
So you've never known anything different other than there's always been staff shortages. That's quite sad, really.
It is.
Because certainly, I've thoroughly enjoyed my time as a midwife, but it didn't mean that I could actually, I didn't have those stresses on me. And, in the early days, I just didn't. I could just focus on one woman, on a labour ward, and just know that I would just have that woman to care for all the way through. And that was a very rewarding thing. Whereas when I used to work, before I retired, when I used to work clinically on the labour ward, it was stressful. You never knew how many women you'd have to look after. And you'd be pulled out of a room to go somewhere else or whatever. So you never totally relaxed.
No. And I think it's become more, what each person needs has become more time consuming. So we're not necessarily just giving care. If you could just give care and do some documentation, that would be, but we have all this documentation. There's all these charts so that we're assessing which are based on sort of providing safety and reducing risk, but so many charts to fill in. And then we have a paper record and an electronic record where I work. So there's all of that as well to consider in your care provision.
Yeah, I mean, women often or sometimes say the midwife was spending more time with her paperwork than she was focusing on me. And you can see why the midwives do that. Like Frances said, if you've got intravenous line in, you've got a chart to fill out and you have to fill it in at intervals or pressure sores or whatever. There's just such a lot of paperwork. And of course, documentation is vital in this day and age for all the reasons we know about. Whereas, right at the very beginning, I would just write probably 2 lines about the birth, normal delivery with an episiotomy, because of course in those days everybody had an episiotomy.
Yeah.
And that was different. So that impacted because they were sutured by doctors in those days. So there were different issues.
Yeah.
But certainly the paperwork has just become mountainous, isn't it?
Yeah, and that when it's that much, I suppose it's time consuming. And like you say, it's almost taking you away, spending time with the patient, isn't it?
Yeah, definitely.
Absolutely, yeah.
And so you both do expert witness work, and we've obviously worked together on cases where we've represented clients who have suffered birth trauma and birth injury. How does the expert witness work that you do impact on how you go about training, mentoring junior midwives and just your clinical practice? Or I know that you stopped clinical practice now, Jenny, but...
Yeah, I think it makes a huge difference because, as I said, I was the lead for risk management, and I could see which cases would actually possibly get into litigation, and I could support and help the midwife and make sure the notes were as good as they could be. And I used to speak on mandatory training as well, about, the kind of things that could help, the way the midwife should work, records, obviously, and really just to make the midwives feel just a bit more confident in what they were doing. And if they, did things in a certain way, then that was absolutely the right thing to do.
Yeah.
Or, converse to that.
Assurance kind of thing, like, this was, what you've done is completely, reasonable practice kind of thing.
Exactly.
I think still working clinically and now developing this sort of expert witness role, they do really support each other for obvious reasons. But I think when it comes to conveying my understanding to staff or students that I'm working with, I think the things that would come down to are the documentation. Like Jenny said, just thinking, when you've made a decision, what was your rationale for a decision? If you're making an omission, what was your rationale for the omission? Which is something I've always felt really passionately about in documentation anyway, because of how I was trained. But even more so now, I review records to form opinions. I think it's so important that those things are really apparent in your records. So there's an evidence of sort of a clear thought processes. If you're not going to follow a guideline, recognition of said guideline, however, woman's choice, offered the woman the choice, or another reason why that you haven't sort of followed a guideline. And as a colleague of ours always said, it was just a guideline.
We do have to cases.
Yeah, it's such a big part of cases, isn't it? What we rely on. What was the guidance and why then wasn't it followed? So that's a big part of it. And also escalation, that's something I'm talking to people a lot about. And I think as all the senior staff in my unit are, really trying to support staff with recognising when would be appropriate time to escalate.
Yeah, that's it.
When I'm doing a case, I'm sure Frances is the same, when I'm actually looking at records, if the midwife has written down the rationale, then that really helps. You can really get inside her head and how she was thinking. And, that's a really good point to take on board.
And do you do expert witness work for claimants and defendants?
I do, yes.
Yeah.
I've always had a split. It's always been 40% claimant and 60% defendant. Right. That is changing now because I've been retired for 12 years and I don't take cases after 2012. Yeah. The claimant work is dropping off because, of course, cases are usually more recent than that. So it is changing. But I still do a fair bit of claimant work, but not as much as I used to do. It's nice to have the balance. I like having the balance.
Yeah. I imagine it's helpful to think of it, makes you encourage you to keep thinking of it both sides.
Yeah, absolutely, yes.
Does sorry, I was interrupting.
There you go.
I was just wondering if the role differs in terms of depending on whether you're acting for claimant or defendant.
It doesn't. No, it doesn't. No.
I suppose that as an expert witness, you're independent, aren't you? So you're looking at the records and giving an opinion to the court. So
yes,
that's the reason why it would differ.
Yeah.
And I think with Frances, I think I've been saying that, haven't I?
Yes.
Right from the beginning. Yeah. You must be independent.
Yeah.
It's in all of our sort of the civil, our procedurals and as well. It's been drummed home to me by my mentor here. And I
always
think,
tell the truth.
Yes, but also, you're not working for either party. You're working for the court to help the court make a decision, and that is how I approach every case.
Something clients often say to me is that they want to make sure that what happened to them doesn't happen to anyone else. Are you able to advise how incidents of birth trauma and birth injury are looked at within trusts and how hospitals learn from those incidents?
Well, that was my role before I left. And risk management sort of took off in about 2000. CNST kicked off, Clinical Negligence Scheme for Trusts, kicked off a lot of the risk management departments. And I was there in the risk management from the beginning, and it was my job. The incident forms would be completed; they'd all come to me, and it would be my job to look at them. And I know this was sort of across all trusts; it was all happening at the same time, and a lot of us risk managers knew each other. And if there was a serious incident, that would be looked at in detail. There'd be a root cause analysis. I would have a group of people, and we would all put our expertise in, and a full report would be written. I mean, I used to write a lot of root cause analysis reports, and that certainly helped writing expert reports as well. And then the systems came in all at the same time. There was a Datix system, was one that was used predominantly across trusts. And then there was an overall system whereby there was a never events where they would all go to one particular system. So there was sort of an overview nationally of, incidents. It was an interesting part of the work, something that I particularly enjoyed doing. So, I mean, I only know from doing cases that their root cause analysis reports are still being done.
Yes, yeah.
So, hopefully it's along the same lines. And also, most trusts have perinatal mortality and morbidity meetings where paediatricians and obstetricians and midwives come together, and nurses, pediatric nurses, usually from NICU. And cases are discussed, and then, there's a general consensus as to could something have been done better, or, that was fine. So that's the way that trusts used to do it, and I suspect that's still going on.
Yes, it is. And that we have a regular, a weekly review of different cases where the MDT come together and will review cases where there was just to sort of review standards of care provision, I think, from a whole team perspective.
Yeah.
In addition to what Jenny said. So I think when we have lots of information provided to us when cases have been investigated and what the learning points were.
Right. I used to write a newsletter every month as well, risk management newsletter, just with learning points from some of the cases we'd had, and just nothing major often, just little, if you do this, do that, then that's helpful kind of thing.
I think it's reassuring it's reassuring to hear you talk about that, because certainly from my experience, when clients instruct me, I see things like you said, the serious incident reports, and there's obviously more birth reflections meetings taking place as well. But you never quite know how it's being looked at internally, and just how people are learning from it. And it's something clients are always saying to me they really want to know. So I think it's just nice to hear how it's looked at, and the fact that you've got sort of weekly meetings happening, Frances, to look over things is reassuring.
Good.
Yeah. Sort of looking forwards, so actually the training I went to, Jill Walton mentioned that recruitment for midwives has increased, and I think the stats she provided were only since December, but there has been an increase in student midwives and recruitment of international midwives, and more staying in the profession now. Just looking at, for midwives thinking of coming into the profession, what skills do you think are most important for a midwife to have now? And what advice would you give to someone contemplating midwifery?
What do you think?
I think, I was thinking about this, and I think, it probably hasn't changed. The skills and the attributes probably haven't changed much in the time, that we've been talking about from 1975 to now. That compassion and the motivation to obviously to do good and care. But I think remembering that it is such a privilege to be a midwife and to be part of this journey with women, whatever stage of it you have the privilege to be in, is just remembering that and remembering the impact I think that you can have on the individual that you come into contact with these women and their families. Is for them, they'll always remember, if you've led with that compassion and that kindness, that people will never forget that.
And that's what women want, compassion and kindness. That's exactly what they want. And it's not always the experience. It's not always the clinical experience they have, like, long labour, cesarean section. It's the compassion and care that often midwives have given them, So you could have a straightforward normal delivery with some grumpy midwife, and that makes the whole experience awful. So I entirely agree with that. And being reflective as well, reflecting on what you've done and learning from the women, learning from what they're telling you.
Yeah. One thing clients always say to me, they remember very clearly language used as well.
Yes.
Be it positive or negative, but that really sticks.
Yes, absolutely.
Yeah.
Yeah, that was something I was really strong on, about using positive language. And not undermining like language like failure to progress or incompetent cervix, or I think that's just awful.
Yeah.
And being a real person as well, not being the woman in room 5 with the OP position, Women need names and made to feel like they're a person, not just a woman in room 5.
Yeah.
So I think that's really important. And yes, if I heard midwives at handover talking like that, I would stop them and explain why it was important to, speak about women by their names and be a bit kinder.
And then looking forward again, I think in the budget, the government has now ring-fenced 35 million for maternity services to boost maternity safety. From your experiences, how would you like to see those funds prioritised?
I think what really came to mind when I was thinking about this was actually investment in staff and getting the numbers up to where we need to, but also investing in staff from a wellbeing point of view. I think
absolutely.
I think we would see a massive change in culture and the safety culture if we were creating, environments that were psychologically safe and led with compassion. And that work is alluded to, and there are initiatives and drives for it, but I don't think it's happening enough within, frontline work. And we know that if, staff are burnt out and struggling to be compassionate, that's impacting on their behaviour to each other, their working relationships, which impacts on safety and also on the experience that women are having. So I think, that we have, I work as a PMA, which is a professional midwifery advocate. And part of that is offering staff restorative clinical supervision, which is really about helping staff to manage, some of that stress and the fatigue that they experience in the stress of their job. So I think investment in staff wellbeing through the PMA role, but also through other drives to make sure staff feel cared for and valued.
Yeah. I think that's absolutely vital, what Frances just said.
Yes.
Agree. Because I remember in COVID when people were taking food and things to hospitals, and maternity units got some, and the midwives and other staff working, they'd get a plate of sandwiches or something, and it really helped the morale, And it was like if you're looking after a woman in a room and if somebody just knocked on the door and said, "Would you like a cup of tea?" That would just make you feel so much better.
Yeah.
Oh, yeah, lovely, thank you. Yeah, 2 sugars or whatever. And that's the well-being stuff. You do your shift, and then you'd go home, and you'd remember that sort of little touch of kindness or something, and just those things just make the difference. But so getting the numbers up from how I would say it is really important.
Yeah.
To try and sort of take some of that stress and distress away. And then, the whole compassionate bit, the well-being of the staff should be paramount, because if you look after the staff, they will stay and they will do a good job. Yeah. And that's vital.
Well, I can imagine as well, we talk about obviously maternal mental health and trauma that mums can sometimes experience, but equally, I suppose midwives are also sometimes working in a traumatic environment, sometimes by what they're dealing with, and they're also working long hours and at the moment dealing with short staff situations. So definitely need more support for their well-being as well.
Yeah, yes. I think it's I think we're starting to get a little bit better at recognising the impact that the job is having on staff, and I think COVID helped with that from a whole NHS provision point of view, recognising that actually what staff experience can be traumatic and does impact on their well-being and their ability to do their job. So I hope that continues, because I think it's long not been recognised.
No. Well, thank you very much for talking to me about your experiences of midwifery. It's been really helpful to hear what you've got to say, and also hear your views about what needs to change going forwards to improve the situation for midwives and for mothers.
Oh, well, thanks for having us.
It's been nice chatting to you, Hannah.
Thank you.
Thank you for listening to Legal Thinking, and thank you to our guests for joining us on today's podcast. If you want to find out more about the topic that was discussed today, make sure to have a look in the show notes where we'll have linked everything up.
And you can find all of the back episodes of Legal Thinking in your podcast provider of choice, and you can also subscribe and follow us on there too. And as always, make sure you leave us a 5-star review on a podcast provider of choice, as that helps other people find us. Thank you very much for listening, and we'll see you next time.
Thanks for listening.